Hello, everyone, and welcome to our 2024 PKD Summit. My name is Michelle Lynn Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, education, advocacy, support, and awareness. This session on metabolic health and its impact on PKD is being presented by Dr. York Pei. We'll be leaving time for a live question and answer session after Dr. Pei's presentation. So feel free to leave your questions either in the Q&A area or in the chat throughout the presentation, and we'll try and address your questions at the end. This session is being recorded and will be available to view on our YouTube channel in the coming weeks. I'll now introduce our panelist. Dr. York Pei is a nephrologist. He's a professor of medicine from the Division of Nephrology at the University of Toronto. He's a senior scientist from the Toronto General Research Institute and the director of the Centre for Innovative Management of Polycystic Kidney Disease, University Health Network in Toronto, Canada. His research focuses on genetic, genomic, and translational research of hereditary kidney diseases, with a major focus on autosomal dominant polycystic kidney disease, or ADPKD. He also made important contributions to genetic research of familial IgA nephropathy, familial nephrotic syndrome, and Alport syndrome. He has published over 180 peer-reviewed articles, collaborated widely with researchers nationally and internationally, and trained numerous clinical and research fellows in hereditary kidney disease. He founded the Center for Innovative Management for Polycystic Kidney Disease in 2016, which provides advanced diagnostic and novel therapeutics for ADPKD. More than 500 patients are currently followed or co-managed at the center, with only over 95% of them involved in at least one research project. Dr. Pei was the co-recipient of the Lillian Jean Kaplan International Prize for Polycystic Kidney Disease in 2019, and the recipient of the Medal for Research Excellence by the Kidney Foundation of Canada in 2020. So before I start the presentation, I'll just note that the volume of Dr. Pei's presentation, which has been pre-recorded, may be different from the volume of my voice. So please feel free to adjust your volume controls if you're having trouble hearing Dr. Pei's voice. And let us know in the chat if you can't hear his voice at all. So this is Dr. Pei's pre-recorded presentation, and then we will join afterwards with Dr. Pei live for a question and answer.
Good afternoon. It is my pleasure to participate in the PKD Summit today and to talk to you about metabolic health and ADPKD. Here are my disclosures. ADPKD is the most common genetic kidney disease worldwide, affecting more than 10 million patients, and it's an important cause of end-stage kidney disease. It is characterized by progressive development and enlargement of eventually innumerable cysts in most patients, which distort the kidney structures and ultimately lead to loss of kidney function. The human kidneys are the most metabolically active organs, weighing only 0.5% of the body weight, but consume 10% of the body's oxygen. Recent studies of PKD1 knockout mouse models have highlighted metabolic reprogramming and inflammation as two important pathogenic features that mediate progression of this model. These pathogenic changes are likely related to overactivity of mTOR and reduced activity of AMPK in the cystic linings. mTOR and AMPK are two energy sensors of cellular metabolism, which I will talk further in the next few slides. To understand the metabolic reprogramming defect in ADPKD, we need to know something about mitochondria, which are tiny structures in the cytoplasm of the body cells. And they act as the powerhouse for cellular energy metabolism by burning fat, sugar, and amino acids from protein. In normal differentiated tissue, in the presence of oxygen, each glucose molecule is being burned in the mitochondria through oxidation to generate 36 mole of ATP, which are the energy equivalent being used for cellular function. When oxygen is lacking, glucose is converted into lactic acid. By contrast, in proliferative tissue such as kidney, tumor, or cancer, as well as ADPKD, glucose, even in the presence of oxygen, are preferentially being diverted to generate lactate, which is a 3-carbon structure, in order to support the growth of the kidney cyst. This defect is called Wahlberg effect and is part of the metabolic reprogramming seen in ADPKD. In experimental model of polycystic kidney disease in mice, the metabolic reprogramming defect can be demonstrated by feeding these mice with an inert glucose called deoxyglucose, 2DG, which cannot be metabolized by the body and therefore blocks the glucose utilization. This defect, when realized in the mouse model of polycystic kidney disease, actually blocks the severity and slows the growth of kidney cysts, demonstrating the effect of metabolic reprogramming as an essential feature for cyst growth. We have also done global transcription studies looking at gene expressions of the cystic lining of patients with a PKD1 mutation compared to the non-cystic kidney tissue from the same patients. And this is a summary of our findings. What is shown in the red are genes or gene pathway that are upregulated or being stimulated in the cystic tissue. By contrast, gene or gene pathway that are downregulated or suppressed in the cystic tissue are shown in green. So you could see the Wahlberg effect in terms of the gene that transport glucose into the cells, as well as metabolic reprogramming defect to redirect the glucose metabolism shown in the red genes within the nucleus. By contrast, the genes or gene pathway that are shown in green are mostly present inside the mitochondria, indicating that the mitochondria are not functioning normally to burn fat, branched-chain amino acid, and glucose. And so we see that the reprogramming of an energy metabolism in the human's PKD1 kidney cystic tissue is much broader than just the defect utilization of glucose, and involve also defective utilization of the fat as well as protein. An important feature of the metabolic reprogramming is the suppression of AMPK in the cystic tissue. And from experimental study, it has been shown that if AMPK is stimulated, you can restore metabolic reprogramming in study of cancer models. Does this also apply to ADPKD? There are multiple old drugs which has been used for many years that are known to activate AMPK indirectly, such as metformin, canagliflozin. These are diabetic medications. They indirectly activate AMPK. Other drugs such as salicylate and relative of the drug aspirin can activate AMPK directly. Other maneuvers such as caloric restriction, which I'll speak more in the later part of my talk, fasting and exercise also indirectly stimulate AMPKs. So we were quite interested to know whether we can make use of this information to devise therapeutic strategy to activate AMPK to restore the metabolic reprogramming defect in ADPKD, and whether by doing so would help to slow ADPKD progression in preclinical mouse studies. We then designed a study in which we use drugs that would be extrapolated from human patients used in the clinical setting to the mouse. And this dosage would be readily achievable in human patients in the normal clinical settings. And they involve the use of metformin, which is an anti-diabetic medication, as I mentioned, canagliflozin, also an anti-diabetic medication, and salicylate, which is a prodrug for 2-salicylate and a direct activator of AMPK. So 3 of these medications are expected to activate AMPK. And we further test combination of metformin and salicylate and metformin and canagliflozin to see whether the combination would have an additive effect. We use this medication in an adult onset mouse model of polycystic kidney disease. And the drug dosage that were chosen would be clinically relevant because they will yield serum drug levels that are normally seen in the patient setting. What we find is that only salicylate in this model was effective in slowing kidney growth in this model. And it's the salicylate or salicylate metformin combination that have the effect in slowing the progression to end-stage kidney disease in these mice. Using the drug dosage for metformin alone, canagliflozin alone, and metformin, canagliflozin in combination, they were not effective in this particular model. And this is the kidney structure of the untreated wild-type mice compared to the mutant mice, and treated with salicylate, metformin, salicylate combination. And as I mentioned, only salicylate or the combination that contains salicylate was effective in slowing kidney disease progression. And we use 2 kidney weight over body weight as an index of the cystic burden, as well as direct measurement of the cystic index. And you can show that both salicylate and salicylate metformin combination were effective in terms of slowing the kidney cystic disease. We also look at the gene expression profile of the cystic kidney of these animals under different drug treatment. In this particular case, we compare the knockout mouse, which is the mutant polycystic kidney disease mouse denoted by the symbol KO. And you showed, and we find that many of the genes that are in the mitochondria, that is modulating the energy metabolism, were severely depressed, as shown in the blue symbols. The red symbol showed that the gene expression is restored to a high activity level, and you can see that when the knockout mice treated with salsalate, SAL, that all these animals were able to restore the metabolic and correct the metabolic reprogramming defect seen associated with the mitochondrial function. Furthermore, we look at another feature, which is inflammation in the tissue level. In the mutant knockout mice, which is shown by the knockout 1 to 12 different mice, they show this upregulated gene expression for inflammatory markers. And by contrast, when these mice were treated with salsalate in the mice that are denoted by the symbol KOSAL 1 to 11, these upregulation of the genes for inflammation is suppressed. And by suppressing inflammation, the tissue was better preserved, and the scarring of the kidney is reduced as a consequence. Furthermore, there were markers called DAMs, which is damage-associated molecular patterns and the receptor. These markers suggest that the inflammation process seen in ADPKD is due to the breakdown of the cystic tissue due to injury that trigger this inflammatory response. And this injurious process is reversed by the treatment of salsalate. We further examine the same model and compare the effect of salsalate with tolvaptan, one of the known drugs which is now used clinically to slow PKD. And what we find is that salsalate treatment has similar effect as tolvaptan. And when you give both drugs, there's an additive effect in slowing progression to end-stage kidney disease in the same mouse model. So in summary, for this part of the talk, we examine the potential use of AMPK therapeutic to restore the suppressed activity of AMPK energy sensor in the ADPKD tissue, using dosage that are expected to be clinically relevant because the drug level in the mouse and in the human patients are very similar. What we find is that salsalate treatment normalizes mitochondrial dysfunction or metabolic reprogramming defect, as well as reduce inflammation in the PKD1 knockout mouse kidneys. Both of these processes are important to mediate the progression of kidney failure. We think that salsalate is a highly promising candidate for drug repurposing and for future clinical trial in ADPKD. Just a little bit more about the salsalate. It is actually a very old drug used for rheumatological diseases. As I mentioned, it is a prodrug of two molecules of salicylate. Salicylate is a relative drug to the drug aspirin, which is acetyl salicylate. But without the acetyl group, salicylate doesn't have the COX-2 activity of aspirin, which is deleterious in terms of the cardiovascular effect. And this drug, salicylate, is only activated in the small intestine, so it doesn't have the side effect of aspirin causing stomach ulcer, for example. Salicylate is well tolerated in human patients for treatment of metabolic syndrome up to 3 and 3.5 grams per day. So this is a potentially interesting molecule, a very old drug that could be repurposed for potential treatment of ADPKD. Lastly, we demonstrate in the preclinical study that this drug may be additive to the effect of tolvaptan. I'd like to turn my attention now to the topic of obesity on chronic kidney disease progression. We have learned from both preclinical and clinical studies that obesity has many effects in the body's function, including creating insulin resistance and therefore potentially predispose patients to type 2 diabetes and its associated effect in kidney injury and scarring. Increased adipose tissue in the body also can generate inflammatory and oxidative marker that could be damaging to the blood vessels of our body. And then finally, obesity can have a number of changes in the gut microbiota, which can have deleterious effect in the kidney function as well. There are two important studies recently highlighting that patients with ADPKD who are overweight or obese have a faster progression rate of kidney failure. The first study highlight using the HALT PKD1 study. All these patients have early to mid-stage ADPKD and had MRI measurement of their kidney volumes. And as can be seen in this slide, people who are overweight or obese have a higher annualized change in their total kidney volume. And this is independent of the genotype effect, age, and sex. The second study made use of the patients that were previously studied in the TEMPO 3/4 clinical trial, which tested the effect of tolvaptan on progression of ADPKD. Again, by looking at the adjusted body weight that is subtracted of the cystic organ, and these studies have shown that patients who are overweight or obese again have a higher annualized increase of their total kidney volume, as well as decline in their eGFR or estimated glomerular filtration rate, kidney function. So how common is obesity and overweight? This is a slide summarizing the global burden of overweight and obesity. And by that, we have to talk about body mass index, which can be calculated by dividing the weight of an individual in kilogram by their height in meter square. So body mass index in adults can be used in categorizing individual into different kind of weight category. Underweight, when it's less than 18.5 kilogram per meter square. Normal weight ideally would be 18.5 to less than 25 kilogram per meter square. Overweight is defined as greater than 25 to less than 30 kilogram per meter square, and obese would be greater than 30 kilogram per meter square, which can be further subclassed into different gradation of severity, for example. In 2022, the World Health Organization did a study and estimated that 1 in 8 people in the world were considered obese. And this level of obesity has doubled since 1990 in the adult population. For adolescent, obesity had quadrupled. We know that 43% of adults greater than 18 years of age in developed countries are now considered overweight, and 16% were considered as obese. What is more disturbing is there are 37 million children under 5 years of age were considered as overweight. So there's substantial burden of overweight and obesity in the normal population. We know that obesity negatively impacts on health, increase risk of cardiovascular disease, high blood pressure, gastrointestinal disorders such as reflux, chronic kidney disease, type 2 diabetes, and musculoskeletal disorder. It also can directly or indirectly damage the kidney. So who is overweight or obese in ADPKD? One of the challenges in assessing obesity or overweight in patients with ADPKD is they have large cystic organs, which, if you don't correct it, can overestimate the BMI and therefore the different kinds of weight category. So the recent KDIGO guideline has recommended that when considering overweight or obesity in ADPKD patients, one should adjust the body mass index by subtracting their total kidney volume and total liver volume and replace the normal kidney and liver weight. We had the opportunity to recently look at our research patient cohort through the Toronto PKD registry to redefine patients using the estimated BMI, whether they are overweight or obese in ADPKD. So we look at all the individuals in this registry who are over 18 years of age, who had an MRI with a T2 coronal cut, and as well clinical data within 1 year of the MRI date. We then measure and reconstruct the three-dimensional kidney and liver volume so that they could be subtracted by their weight, and then replaced with the expected average normal kidney and liver weight. So here are the results. There are 632 patients. The average age is 45 years. Roughly half were women. Most of them have a pretty normal creatinine or eGFR, slightly decreased from normal. So this population generally have mild to moderate polycystic kidney disease. The height adjusted total kidney volume is about 900 ml per meter, and the mutation class are shown here. About roughly more than 1/3 of them had the more severe PKD1 protein truncating mutation or indel. These are the more severe mutation class, and then the rest have the milder disease associated mutation class. What we find that in terms of the classification of overweight and obesity in ADPKD, if we just use the BMI without adjusting for the cystic organ, we would potentially misclassify 10.5% of the patient into either obese when they are just overweight, or overweight when they actually have normal weight. So our study highlighted the importance of using the adjusted BMI for the overweight or obesity classification, because once you label patient as overweight or obese, you may intervene with therapeutic intervention such as medication, for example. So it is important to do it accurately. One interesting aspect is that both ADPKD and obesity share a central pathogenic mechanism, which I have already mentioned earlier. That is the decreased activity of this energy sensor, AMPK, in the PKD cystic tissue. In people who are obese, there's a generalized decrease in the AMPK activities, particularly in the pancreas and in the fatty tissue. And this can also lead to the systemic effect related to the obesity and metabolic syndrome. Decreased AMPK activity in the PKD cystic tissue, we know, can lead to increased fluid secretion within the cystic cavity, as well as increased cellular proliferation and the metabolic reprogramming in the mitochondria. So if you activate the AMPK, you could reverse these defects. By contrast, in obesity, in patients who are overweight or obese, they also have decreased AMPK, which can be related to the metabolic syndrome. And again, if you activate AMPK, then you could reverse many of these processes. The share mechanism through AMPK suggests that we can use drugs that are active in obesity to potentially treat patient cystic disease, and possibly this may slow the PKD progression. So the next part of my talk will focus on potential therapeutic intervention for obesity and ADPKD through activation of AMPK. You have seen this slide before. As I mentioned earlier, AMPK can be activated indirectly by older medications such as metformin and canagliflozin, as well 2-deoxyglucose, which in experimental study actually slowed PKD progression in animal model. I have shown you our work related to salsalate, which is a prodrug for 2-salicylate that can activate AMPK directly. And all these maneuvers can slow PKD progression in experimental mouse model. What I have not shown you is the use of caloric restriction, severely restricting calorie, fasting. Different maneuver of fasting also have similar effect in slowing PKD progression in other experimental studies. So one set of experimental maneuvers that are particularly relevant for ADPKD and obesity are highlighted here. And they include caloric restriction, which I'll speak more, use of some newer medications called SGLT2 inhibitor for diabetic treatment, type 2 diabetes control. These stand for sodium glucose cotransporter 2 inhibitor. This class of drug cause wasting of glucose from the blood into the urine and therefore lower weight and also improve the control of patients with type 2 diabetes. Another new class of drug are called GLP-1 receptor antagonists, stand for glucagon-like peptide 1 receptor agonist, as well as GLP-1 and then GIP receptor antagonists. These two classes of drugs are really quite new, and you have probably heard of it in the news as the wonder drug for obesity. And both act by suppressing the desire to eat or appetite, and thereby was successfully shown to reduce weight quite dramatically for treatment of obesity as well as type 2 diabetes. All these maneuvers are potentially applicable to patients with ADPKD who are obese, but whether they will act to slow PKD progression is unknown at this time, and they are being tested for the potential to slow kidney disease progression in ADPKD in a number of clinical trials. Hopefully, within the next 2 to 3 years, there will be results from these studies which will guide clinical management and whether these classes of drug or maneuver should be added to ADPKD patients. The last part of my talk will focus on dietary intervention in ADPKD. And there are different kinds of dietary intervention I like to highlight. They include dietary caloric restriction, intermittent fasting, time-restricted eating, ketogenic diet. Dietary caloric restriction is a very severe restriction of caloric intake by at least 30% less of what would be required for the ideal weight of the patient. So this patient would be quite thin if they adhere to this diet. And it's quite difficult to achieve in human. Intermittent fasting also restricts caloric intakes and generally employed 1 to 3 consecutive days of fasting, during which time the patient would not be eating, but they are allowed to drink water or bone broth that are devoid of calorie. And during this time, they would induce a ketotic state, and after using up the liver store of glucose, and that would lead to the burning of fat and weight loss. Time-restricted eating is much more simpler, and they require that all the eating in a day are done within an 8 to 10 hour window. For example, the patient would not be eating breakfast, but can eat lunch and dinner within that time window, as well as afternoon snack, and they could eat whatever they generally eat during the time window. And finally, a ketogenic diet requires the consumption of high fat, moderate protein, or low protein, as well as dramatically reduced carbohydrate. And this can result in metabolic profile that are similar to caloric intake and a ketotic state. So far, we have some preclinical and clinical study of these kinds of maneuvers. And in the preclinical study, caloric intake has very dramatic effect in slowing PKD progression in mice. In clinical study, these are very small study that demonstrate that it is feasible to do, but whether it actually slowed the kidney growth is quite uncertain at this time. And there are some safety concern about potential adequate hydration, nutrient intake, and long-term maybe bone loss and anemia. Intermittent fasting has been done in non-PKD preclinical study and have been shown to improve insulin sensitivity, reduce blood pressure and heart rate, and promote metabolic reprogramming. And clinical study have not been done in ADPKD patient, but has been done in non-PKD setting, which has been shown to be safe and feasible. And again, there are some potential concern about hydration, adequate nutrient intake, and adverse effects also include hunger, fatigue, irritability, cold intolerance, and difficulty with sleep. Time-restricted eating has been shown to improve body composition in insulin sensitivity in non-PKD models, as well as non-orthologous PKD model. So it is unclear what it would do in ADPKD. These studies were somewhat promising and had led to some preliminary clinical study, which I will show you in the next few slides. Time-restricted eating is relatively easy to adhere and is associated with minimal side effects. There has been a lot of interest in the use of ketogenic diet in ADPKD. And I just want to highlight some of the key message that we learned. In preclinical study, ketogenic diet has been shown to result in reduced cystic disease severity, and the administration of the ketone body, beta-hydroxybutyrate, was also shown to decrease cystic disease in a non-orthologous ADPKD model. In terms of human study, up till now, they are really quite limited, and they're restricted to online survey case series, which are retrospective study, potentially that could be biased and uncontrolled. So even though they're interesting, we should be careful in not over-interpreting this study. The RESET PKD study is a feasibility study involving only 10 patients from a German center, and showing that it is feasible to do this type of ketogenic diet. And then more recently, the same group had published the keto trial involving 63 patients. And so I will go through these studies for you. The keto ADPKD trial is a randomized control trial involving 66 patients, and they are randomized into 3 groups. The first group consume a keto diet. The second group is a standard diet. They act as normal control. And the third group, patient practice water fasting. So they're kind of like an intermittent fasting type of diet. And the treatment lasts for 3 months. And the results of this study show that patients who are on the keto diet seem to have a lesser decline of their kidney function. They do have decreased body fat. They may experience what is called keto flu, which is kind of like a flu-like symptoms. These patients also have increased lipid in terms of the LDL cholesterol, which can be considered as potentially the bad cholesterol, as well as increased uric acid, although no patient with gout was experienced in this trial. So you can see here on the left-hand panel that the group with the keto diet in the brown line seems to have a bit higher estimated GFR than the other two groups. And that based on creatinine or cystatin measurement. So what can we interpret from this trial? First of all, it is a small study. Whether the kidney benefit is due to the trial from ketogenic diet, I think is uncertain because of the small sample size. We know that patients with ADPKD can have quite variable disease severity and progression. So randomization with a small number may not have patients with equally same risk profile. So if there's a difference in the risk profile, then it could bias one group versus the other. There was some question whether the ketogenic diet can decrease muscle mass, and since creatinine is derived from muscle, that this would result from what appeared to be better eGFR. However, the cystatin measurement was used in this study, which seemed to suggest that the kidney function change may be independent of the change in muscle mass. Finally, the long-term effect, whether this is something that is sustained or not, is unclear since it was only 3 months long. What we can conclude is the ketogenic diet appears safe in a short term and may be potentially beneficial, but larger study with longer term treatment is needed. Potential risks of a ketogenic diet are also being considered here. As I mentioned, when you're on a ketogenic diet, your LDL cholesterol can also go up. And it really depends on what kind of fat that you eat to increase the composition of the percent of fat in a ketogenic diet. And if one would include saturated fat or maybe trans fat, that could be potentially not as healthy. Another risk that was not shown in the previous slide is that a ketogenic diet can also reduce urinary citrate, which is an inhibitor of kidney stone, and patients who are on a ketogenic diet can potentially be susceptible to increased risk of having kidney stones. And finally, it is possible that some patients may develop metabolic acidosis, and that may over time affect their bone health. Dr. Thomas Weim from Santa Barbara had been a pioneer in developing this kind of ketogenic diet in preclinical study as well as in human. And the program called Renew PKD Nutritional Program employed a plant-focused ketogenic diet with low oxalate and phosphate, and as well as education, supplement with ketocitrate, which is contain beta hydroxybutyrate, one of the ketone body, and potassium citrate, oxalate restriction, and slight protein restriction, as well as mindfulness. So the incorporation of this 12-week program is part of this plant-based ketogenic diet program. We have been working with him to try to design a pilot clinical trial, single center, to test the tolerability, safety, and efficacy of their program in patients with a prospective parallel arm of matched control patients not on this program. And the entire trial will involve 40 patients per group. And these are the inclusion-exclusion criteria. We will focus on patients who are at high risk for progression based on the Mayo Clinic imaging class 1C, 1D, 1E, who have a reasonably good kidney function, blood pressure control. At baseline, both kidney function and MRI will be performed in both groups of patients, and clinical intake questionnaire about risk factors will also be collected. The intervention group will undergo a 4-week renal program to learn about a ketogenic diet and to try with the supplement, and then they will continue throughout the 1-year study to adhere on this diet program. The control group will be continuing on the standard North American diet, and none of these patients in the control group will practice either fasting or any dietary maneuver that could potentially contaminate the study. And at 3, 6, 9, and 12 months, a clinical visit will be given for both group of patients to assess their biochemistry, kidney function, as well as clinical symptoms of tolerability and safety. And then at the end of the 1 year, both groups will have an MRI to document their kidney volume and liver volume to assess the effect of the intervention. Unfortunately, at this time, the trial is not able to go on. We have been trying very hard to apply for funding, but we have not been successful. So I know that many of you are very interested in this, but at the moment we are not able to launch this trial. In conclusion, metabolic reprogramming is an essential step to support cyst growth in experimental models of polycystic kidney disease. Overweight and obesity are independent clinical risk factors associated with chronic kidney disease progression in ADPKD. Body mass index in patients with ADPKD should be adjusted, i.e., by subtracting the cystic kidney and liver weight and replace it with the average normal kidney and liver weight before it can be used to assess the different weight category of patients. Future studies are needed to evaluate the effects of dietary intervention or new drugs targeting obesity in ADPKD. More specifically, these agents, whether they may have added benefit to slow ADPKD. I also like to acknowledge and thank the past and present members of the Center for Innovative Management of Polycystic Kidney Disease, as well as all the granting agencies for their support of our work over the past 10 years. Thank you very much for your attention.
but we are going to jump in right now to the questions that people have for Dr. Pei. And I know that people have been putting a lot of them both into the question and answer area and also into the chat. So let's just get going. Is that all right with you, Dr. Pei?
Sure. Can you hear me okay?
I can hear you. Yes. Welcome. So one person is asking, obesity and PKD progression could altered microbiome, I'm assuming in the intestines and the stomach, be the connection between obesity and PKD, as we know that those with obesity have different microbiome, less diversity and type than those without obesity.
Yes, I think it is quite possible, but it's not an area that is well studied. Microbiome is very complicated, as you know, and the diversity of the different organism may have a role in terms of the promotion of obesity. And so I think this is an area of unmet need, I would say, in ADPKD patients.
Someone else is asking, what does it mean for people who have a normal BMI? Should they be doing any of these treatments like intermittent fasting or time-restricted eating?
Yeah, I think it's people who have a normal adjusted BMI, a patient who have polycystic kidney disease, I think at this time I would not recommend that because sometimes you could lose more weight and I think we don't really fully understand the risk associated with this kind of maneuver, especially long term. So I think they are not completely harmless.
Okay. Someone else is asking, I've heard that Ozempic and similar drugs are helpful to slow the progression of chronic kidney disease. Is this true? And are there any clinical trials in which Canadian PKD patients can participate?
So the short answer is no. There are some trials being organized in Germany that are going to be testing these kind of agents, but I think, as you know, like it's a lot of effort to try to even do a single trial, and I think that so at the moment I don't think that I'm not aware of any group in Canada that is planning to do a trial involving these agents, but definitely they should be tested in ADPKD patients.
Awesome. Another question is salsalate an NSAID? So that's one question.
Yes. So it is not quite an NSAID. So this is a very old drug. I remember as a medical student, like actually having used it in rheumatology, and this is a drug that has never been patented. So right now you can buy it, but like it's from like manufacturers, and then they don't necessarily provide very good quality control kind of and because without patent, no industry is willing to promote this drug. And at the same time, back like 20, 30 years ago, Bayer, the company that modified this, the salicylate and added an acetyl group, converted into aspirin and patented, become a wonder drug. So, but there are distinctions, and it is not an NSAID precisely because of the lack of the acetyl group, and therefore it devoids of this COX-2 activity, which in the NSAID literature has been thought to potentially promote cardiovascular risk complications. Additionally, as I mentioned in my talk, this drug is not activated in the stomach, but only in the small intestine. So it also doesn't have the side effect of aspirin in causing stomach ulcer. So there are some distinct advantage of using this old drug. The difficulty is getting it in good quality and also how to promote it to be tested in clinical trial when it's not patented. And we know clinical trials are very expensive, and no pharmacological company are willing to put in the money for a drug that is not patented. So that's the dilemma of drug repurposing.
Very good. The second part of that person's question was positive results on keto could be due to increasing ketones or decreasing visceral fat or decreasing muscle mass. Are studies planned to tease apart those individual factors?
Yeah, so the short answer is yes. I think we try to do that with that trial that I show you, but like we have not been able to launch it because of lack of funding. I think that there may be other centers that are hoping to do that. There is one center in the US that are using similar kind of strategy, but as I understand, they also have problem getting funding. There is a group in Japan that is doing that, and Dr. Hori, and he also had worked with Dr. Wine. So I think I don't know how far they have in terms of the progress of the trial. So hopefully with time, like we will have some additional information to inform us about the risk and benefit in a longer term setting.
Thank you. Their next question says, hi, Dr. Pei, would you please provide a bit more details on the interventional PKD diet study, like at 3, 6, 9 months, which biomarkers are essential to measure regarding the kidney function, and if patients are on tolvaptan as well in the study?
I presume they're talking about the Toronto pilot trial?
I'm assuming.
Yeah,
yeah.
So the biomarkers are biomarker that include inflammation markers, as well as potential risk of kidney stone, the deleterious lipid, the LDL, which can be fractionated into small and mid-sized LDL. And there's some literature to suggest that not all LDL are atherogenic. So we have to separate the different compartment in order to answer whether elevation of LDL is a bad thing in people who are taking a long-term diet. There are a lot of biochemistry for the chemistry changes in the urine, which may promote kidney stone. So this would be kind of a safety measure. Those are the general kind of measure. And then the MRI is used to quantify whether there's change in the kidney volume, which we expect probably we would not be able to detect a significant difference because of the small sample size. We do and would be potentially able to measure the skeletal muscle mass to address the issue whether the ketogenic diet program actually cause muscle wasting, and therefore the marker of creatinine would not be reliable. We also have non-creatinine based kidney measurement incorporated in the trial.
Thank you so much. So those are the questions that have been live. If anyone else who is still on this session has a live question, please feel free to put it in the Q&A and the chat. We do have a few questions that have come through when people registered. Dr. Pei, would it be okay if I shared some of those with you?
Yeah.
Are the influences of some of these interventions, like intermittent fasting and time-restricted eating, are they relevant to a post-transplant patient or just to a pre-transplant management of PKD?
I think they are relevant to any patient that have an adverse metabolic profile because they are overweight or obese. So I think like getting our metabolic profile optimized and improve, I think in the long term would have a good impact, not just on the kidney, but on the blood vessel, on the heart and multiple organs. So I think this is something that is like would make sense to try. The question is whether you want to use a dietary intervention or versus medication, because now there are competitive choices, and particularly some of these newer medication that can result in a lot of weight loss and improvement of the metabolic profile. On the other hand, I also want to emphasize these new medication, we also don't have very long-term kind of follow-up, and they're not completely harmless either. They can cause sometimes intestinal problem and even bowel perforation in some patients, and so they are rare. I mean, but this is something that that is should be considered. Whereas a dietary intervention seems to be more holistic and natural. That I think in any event, I think eating the right type of food should also be emphasized. I think there's a current trend of eating less carbohydrate or starchy food, increasing the amount of fatty food, particularly good fat, and maybe moderate kind of protein intake. And it would be consistent with good health, whether you want to consider any of these fasting or regimen. But I think that should be part of our normal healthy lifestyle.
Thanks so much. And there actually were a few questions before the session from registrants about carnivore diets, which of course are a completely saturated fat diet. Based on the information in your presentation, am I right in understanding that the risks of the saturated fat may not be appropriate in PKD patients?
Yeah, I think again, this is evolving question because there's not a lot of hard data to help support it. And I know that there are some experts who are promoting this. And I think in the internet, there are a lot of different opinions. And ultimately, I think what is important is that we should have good clinical data to guide us. And we should temper our enthusiasm, like, because all these will come and go, but I think that safety also should be a concern. So I think adequate protein intake is important, particularly as we get older in the older patient, because it is well known that as one gets older, one would have the tendency of losing muscle mass. So you want to have adequate amount of protein to maintain your muscle mass, plus like exercise but the carnivore type would be like an Atkins diet, like would be eating a lot more. So I think that I would say that it would be premature to recommend this type of more extreme diet. I think one should probably act more on a conservative side until there are good clinical data to inform what are the best choices and the risks.
And the last question I have for you is someone's asking, can losing weight, so just losing weight, regardless of diet, reverse the progress of ADPKD? Or are we just talking about slowing down the progression?
My sense is that more than likely is not going to be sufficient to reverse ADPKD, which is kind of like the best outcome you can. I think slowing ADPKD would be already a very good outcome, but I don't even know whether it is possible. I think one have to have good clinical study. And remember, the problem as you change your weight dramatically, the kidney weight will also change, and then the usual metrics of measuring cystic disease burden may also be biased and be confounded, and how to interpret. And then as you lose weight and muscle mass will also decrease, and the creatinine will lower, which will give you a higher eGFR. It doesn't mean that the kidney function is actually better. So I think one have to bear that in mind, and one would have to use non-creatinine-based means of measuring kidney function. And there are very few studies that use this type of approach at this time. They should be done.
Okay, thank you so much, Dr. Pei. I really appreciate you going a little bit over time. Again, I'd like to apologize to everyone for the technical problems. We're so thankful that Dr. Pei could provide the presentation. It was very informative, and we're so glad that you could be here to answer questions. This session will be recorded and available on our YouTube channel at regular speed. We were playing it at 1.25 speed. Just to save time, that it will be at regular speed on our YouTube channel. And if anyone has any additional questions that you'd like to ask nephrologists or researchers like Dr. Pei, please feel free to email us anytime at the email address that's in the chat, ndpkd@npkd.ca. So thank you everyone for joining us today. Thank you so much, Dr. Pei.
Thank you, and thank you very much.
All right, bye-bye.